Hey everybody, it's Kevin and it's Jaron from RPH Ally, and we are bringing you a brand new show, the Pharmacy Rebrand Show. Jaron and I have been talking for a while in lots of different roles for me, developing roles and evolving roles for Jaron. But we really thought, what needs the biggest evolution is probably our profession. So let's talk about where we've been and where we're going right after this clip. Super excited, buddy. Like, this is one that I've been looking forward to for a long time. You and I have been talking about getting this up and rolling. So really give us a little bit of background, Jaron, on what are we doing here and why are we doing this Pharmacy Rebrand Show? Like, what's the point of what we're putting together?
Yeah, thanks, Kevin. You're right. We have been talking about this for a while, and it's been slow going, mostly because I just was trying to get too many. I have a tendency to just bite off more than I can chew, and trying to get a whole lot of different things launched all at once. And in just our discussions, I think we both came to the agreement that our profession is in need of a rebranding or a restructuring. And I think, we've been talking about it for a decade or so, that, in the coming years, healthcare is going to go through a lot of reform and massive changes. And by default, our profession will as well. And especially with artificial intelligence really starting to ramp up, it's now is the time for us to kind of take the mantle of our profession and identify what kind of impact we can make, what kind of things we've been trained to do that we just haven't done up to this point. And how can we utilize our training to prepare ourselves and brace ourselves to be something that cannot be replaced, something that will survive an overhaul of healthcare and pharmacy profession in general. So it's time for us to kind of discuss ideas and concepts about the future and how we can utilize pharmacist training and services into and embed that into the future of the healthcare system.
Wow. So Jaron, give me this. I know that there's a few initiatives going on with, what we're trying to push across the line from a Senate standpoint. And you've been very active with travel and talking to folks at CMS and otherwise. What are you working on right now, Jaron? And tell us a little bit more about the summit that we're hoping to get put together and running sometime really soon. Summit Symposium.
Yeah, absolutely. So I originally created a coalition called the Collaborative Coalition of Innovative Physicians and Pharmacists, because there is an actual growing market of physicians who are interested in collaboration with pharmacists and how to bill for those services under their own wing. And there's a lot of ways to do that and make it work that we have historically not done. Unfortunately, a lot of the regulations in place have made it very difficult. And I think, people are probably familiar with this if they've seen previous episodes where I was featured in some other shows with you and Jenna and other times where I've spoken in the past as well. The regulations made it very difficult. So we created this coalition to kind of streamline and simplify those regulations so that this could be a service that is more readily accessible and something that you can scale on a large scale into the healthcare system. So that's how it originated. I teamed up with an attorney named Lee Davidian at the Dumbarton Associates in DC. And I was introduced to her by Dana Saffel, a great mentor of mine. And it was my first interaction with any attorney. And it was life-changing in a good way.
Wow.
I never thought that, of all the jokes I've heard my entire life before I knew any attorneys was, they're all shady, crooked people. But this has been nothing but positive for me. She's kind of given me the platform, and in a way, she's legitimized everything I've been working on for the past 6 years.
Amazing.
So after creating the coalition, we got a lot of buy-in from a lot of different physician groups. We've had good response with doing work on the Hill with senators. We've gotten ASCP to be supportive, obviously. And so ASCP is and Lee Davidian with me are kind of building this summit. Because one of the things we've run into in our discussions with CMS as part of our coalition work is that, one of the complaints they have is that pharmacists are begging and pleading for provider status, and yet we have not utilized any of the tools that they have made available to us as stepping stones. We haven't used any of them. MTMs is partly an example of that, but not so much.
Mm-hmm.
Our ability to use incident to billing it's been there for a long time, and we have not utilized it sufficiently. And there's several reasons for that. We have had the opportunity to team up with physicians to do CCMs. There's been very minimal amount of that going on. Same with BHI, annual wellness visits, collaborative practice agreements. All of these items are tools that CMS has made available to us so that we can be more of a part of the healthcare team. And we just haven't grabbed those tools and run with them. And so their complaint is, why are you asking for lightened restrictions on incident to? Why are you asking for provider status? You haven't even done anything with the things that we've made available to you. So why would we give you more? And so that is what generated this symposium, because we know there is a lot of pharmacists out there that are indeed doing very innovative things. They are collaborating with physicians. They're billing for their time and their services, whether it's private pay or teaming up with third-party payers. There is a lot of pharmacists out there doing stuff. And as usual, we have a way of doing these things without making it, a big hullabaloo or a big obvious thing. We're all kind of operating in pockets in our own little silos, making great things happen on small scale without communicating with each other. And also, another reason for this symposium, we have a lot of great organizations that represent our profession. APHA, ASHP, ASCP, the community pharmacy. There's one for psych pharmacists. There's a lot of great professional organizations that represent our profession. Mostly the focus that drives these professional organizations are pharmacy driven. They are product driven. Mm-hmm. And as great as that is a very, very important part of our history. It's an important part of our profession. But the day is coming where we have to put our money where our mouth is, and we have to start billing for our time. And we aren't getting provider status anytime soon. So we need to utilize the tools that are at our fingertips. So we want to use this symposium as a method of putting together a bunch of like-minded pharmacists. We're thinking it'd be fairly small, 35 to 50 pharmacists that we bring into a location. Hopefully it's not a virtual one. It would be a live session, but we'll see what kind of things happen. But we want to, first of all, get us in a room, start collaborating with ideas and communicating how we can, things that we're all working on that we can all learn from and benefit from each other. We want to create professional support that supports pharmacists. Pharmacists are what do services, and we have much more ability and training than we are currently utilizing in our current market. So, part of the problem is we all go to this great pharmacy school. We get in 6 figures of debt, and then we graduate and realize that the opportunities we want are not exactly easy to do unless you get a lot of additional training and education. So after you graduate in 6 figures of debt, now you have to hand out another 5 figures of money just to get trained on how to do these unique and collaborative services that are not widely known and not widely used. Mm-hmm. So the main objective is kind of get us in the same room, get us to start communicating, get us to start building an education network and a professional network. And currently ASCP is interested in helping us to build this network as a support to pharmacists, so that now we can, and also, as you and I have talked as well in the past recently, we also want to start reaching out to pharmacy schools and start getting them on board with educating young pharmacists in school to be aware of these items and these resources available, so that when they graduate, they don't have to pay a whole lot more money just to figure out this aspect. So there's a lot of potential here. I think it could create residencies. It could easily expand the role of our profession if we start utilizing these services, prove our value. And I'll be honest, every time I team up with a physician, once it happens, they never want to go without it ever again. And I think as a profession in general and as a whole, we need to start taking every opportunity we can get to make it so that we can build off of that as people see our value. So I'm forgetting where we started from, but I'm hoping I ended where we were hoping to end.
Well, you're good, buddy. I think that the one thing that you went through is just the amount of passion you have for the profession to actually take these steps, like to make them real, not just talk about them, but do something so that we can actually collectively say, here's an actual opportunity that you can take the reins of and do this for a career, not a pipe dream, not a someday, not a maybe if we get all of our cards to line up right, but we can actually put these things together and make them a reality. I think, the best thing to probably do is just to take a step back and go, why are you talking about rebranding pharmacy? Like what did we look like that we need to have a rebrand, Jaron? Like in your feeling from the perspective of patients and providers that you've worked with. I mean, so here's one thing. Let's start with providers. You mentioned that once you start working with a provider, they never want to go back, right? They want to utilize Jaron or another pharmacist doing something very similar to what Jaron is doing and pushing the clinical envelope and being a pharmacologist and a true expert in everything treatment. Why didn't they feel like that initially? Why weren't they hunting down for a pharmacist to be joining their team? Why did you have to go to them?
Mostly because they just don't know it's an option. And that's our biggest obstacles. People don't know that these opportunities are available. And if you do know, it's you either actively search it out or you stumble upon it by chance. And so our biggest obstacle right now is just getting the information out there that this is an option, because nobody really knows that it's an option. They have to find out by chance or actively find what opportunities are out there. Does that answer your question?
Yeah, I think that in general, like having to find those opportunities is interesting, because in medical school and training, like when I was in pharmacy school, for example, there's a lot of collaborative practice thoughts going on. How do we start interweaving all these different professions together? That has not been the case for very long, Jaron. Like there were lots of silos that were put in place to say, this is what these guys do. This is what these folks do. This is what these guys do. And we don't cross paths. Like we do what we're supposed to do. And that's how we take care of patients. And being able to see that transition is great. So we're seeing different generations of care providers come out. But the previous generations of physicians were not looking at pharmacists as colleagues. They're looking at pharmacists as a dispensary role in an apothecary setting to be able to push pills across the table that I tell them to push across the table. And that was how they were reimbursed. That was how they were treated. And that's how the laws and regulations were written very purposefully and pointedly by AMA guidance. And so I think there's a big transition from going from that mindset toward, I want to collaborate with these individuals because they have an incredible specialist mindset and knowledge that I don't have, and puts my patients in potential harm's way. And so I think there's the huge breakthrough is, you and I have talked about, why are pharmacists viewed as not another medical specialist, as opposed to just being they're pharmacists. They're not a medical specialist. They don't know patient care as well. Why do you think that has been stamped into our colleagues throughout the medical profession so deeply?
I like that. And, you know, when you look at the history, you're absolutely right. There is currently a paradigm shift in the physician view of what a pharmacist is and how they can help. And in the 90s, when we started making collaborative practice agreements available, when we started to make the PharmD the requirement, we still couldn't get our foot in the door because physicians just did not value our position next to them. And that is now changing. And the attorney that I work with, Lee Davidian, she did a presentation at a conference and met some oncology physicians who, as soon as they heard this was an option, they were thrilled. They reached out to her and said, how do we, you know, make this work? How can we hire a pharmacist? How can we learn more about this? And I think historically, to answer your question, the biggest problem we have, and this is just my opinion, and you know, this is my perspective and how the conclusion I've come to, and I'll give you a couple of examples. We have, like I said earlier, we've based our profession strictly off of a product. And as valuable as that is for us to be knowledgeable about the products that we sell and we dispense, it also created a conflict of how we perform services. Because think about the time when they started to make it a legal requirement for a pharmacist to counsel a patient on a medication that they are picking up. Think of how this created difficulty in a workflow that is strictly, perfectly designed just to dispense products. And you have a very knowledgeable person who has to be present in that pharmacy. And now you have to take that person away from what drives their pharmacy by dispensing product. They have to pull them away from doing that to do something for free, to consult. And that is why the consulting aspect of community pharmacy has not reached its potential, because you have to hurry, because you can't spend much time there because we don't get paid for our time. So the whole thing that we're trained to do, ask open-ended questions, all that stuff that we're trained to do in the counsel window has to be summed up in 10 to 30 seconds. And so we're not asking open-ended questions. We are hurrying through as much bullet point drugs.com information that we can regurgitate as fast as we can so that we can get back to dispensing product where we generate revenue. And every time we have to do a service in a pharmacy, it creates this conflict that does not jive with dispensing a product. And another example is just when COVID hit. You know, even before COVID, we started to see a lot of vaccines, pharmacies offering vaccines and administering vaccines. And then when COVID hit, it went to a whole new level. And now we had to not only administer 100 vaccines a day, but we could not let that derive us from our usual statistic of dispensing 500 to 700 scripts every single day. And so because of the fact that we had dispensing metrics to meet that conflicted with the time we had to spend administering vaccines, it created a lot of burnout. And that is at its core, in my opinion, one of the key components to why our profession has not thrived in providing services. We have to make it so that the service is something that can be reimbursed, and if we can separate our services from the products, we remove conflict of interest and we remove that potential where we have to hurry and do the bare minimum of that service so that we can get back to the product. And as long as that is there, in my opinion, that's why our profession has never met its full potential. And, you know, obviously I'm very opinionated on the matter, but when I look at the current standard of practice for consultant pharmacists at least where I live, I can't speak for everywhere. It has been very disappointing to see that our key components of consulting is make sure metformin is with food. Make sure we rinse and spit with Advair. We're giving them info that is already made available to them from their electronic health record. When they input the order, it automatically generates this information. What we need to do is clinically assess the appropriateness of every medication, identify where we can cut down, identify where gaps in treatment are, identify when appropriate dosing has been utilized, etc. The opportunities for us are out there, and we just don't have time to do it because we don't get paid for our time. So I hope that answers your question.
Yeah, it really does, Jaron. I'll bring this image up real quick. I mean, if you do a Google search on what does a pharmacist look like literally that is what is pulled up on a Google
Everything search. Is with a drug in the background. Every single one.
Every single one, right? And I think that it makes sense. Like, it makes perfect market sense that a patient would see us as being, that's who gives me my pills. And from a physician standpoint or from a provider standpoint, they're saying that's who dispenses the pills that I write for. And from a payer standpoint, that's who takes these medications and dispenses them to the patients that we're paying for these pills and the margin to pay for their individual salaries, potentially. We can look at it that way. And from a policymaker standpoint, that's the way that we're writing all of our laws to make sure that they're keeping our patients safe with the product in mind. And so I think unless we can find a way to literally detach ourselves from that product entirely, and I'm not saying that we should have everyone in pharmacy no longer work with product.
That's not feasible.
It's not feasible, and it discredits a lot of incredible services that are done by compounding pharmacists and those that are really manipulating product to make sure they're a best fit for individual patients, and also the roles that are necessary to financially make sure that our patients can afford the product that are going across the counter, right? And I think there's a lot of value to that. But when it comes to the way that all of these other entities are viewing us and why we have to rebrand, is just the fact that if someone looks at pharmacy and they're thinking those pharmacists are getting paid off the margins of those products, then that doesn't mean there's additional meat on the bone for us to get paid per. RVUs is a bad example, but there are no value units associated with a pharmacist's time, right now. And I think that is the next kind of phase that we have to go to. I'm sure a lot would argue that there are some problems with that physicians are facing today, which I don't disagree with. But one last story that I have, Jaron, is I saw just recently on social media, it was a good post. And there's been several recently about here's what pharmacist salaries have been, over these last few years. And another one was based on a pharmacist comparing the way he's reimbursed on a holiday to come in and fill a script that took him 45 minutes to do versus what that would have been in terms of a charge from a plumber to come and help him at his home. And plumbers are great technicians and skilled individuals and have great knowledge. I totally agree. I would hope that us PharmDs, the individuals that went and have a doctorate and knowledge that actually impacts the human body, would get paid at least an equivalent to what a plumber is making, right? And he said the plumber is making around $185 just to show up at the door, and he got paid 47 cents. And I thought, that's all we need to know. I mean, when it comes to why do we need to rebrand our profession and why do we need to reevaluate the way that other people are looking at us, it's exactly that reason. And I think that the cost-based reimbursement models, the subscription models, a lot of those other ones that are out there, I think are great that they can detach us from the payers in general. But when it comes to the broader scope of all of our patients that can afford and are currently in the current paradigm of healthcare, that's not everybody. Like, it's a very small grouping of individuals that are going to fit there. And for us to be able to impact patient care in our communities, we have to have that buy-in and that rebranding on all levels, from patients' viewpoint, providers' viewpoint, payers, and those institutional policymakers, for us to really make a difference. So I'm super excited. Jaron, to lead us off, tell us kind of that list of those 6 things you read off that we'll be talking about through these next few episodes, what we're going to dive into.
Yeah. So let me pull them up here. I just literally wrote these like a half hour ago, just discussing with the attorney. She said we need to come up with 4, and I gave her 6 because I always go way more than I should when talking about our profession. So, first of all, expand the role of pharmacists. That's obvious. Like that's at the core of everything that we do, right? That I do right now, and that's the core of everything we've talked about today. To meet the needs of healthcare of today and tomorrow, because healthcare is going through a transformation right now. They're getting away from fee for service. They're going more into outcome-based payment models. Currently, none of these proposed outcome-based payment models have any involvement of clinical pharmacist services. They're going to include dispensing somewhere in there, obviously. But in order for us to survive this metamorphosis, we have to find a way to put ourselves on the team-based aspect on the front lines of healthcare. To create and build a support system and education for pharmacists interested in innovative practices. Kind of like that's what I was talking about with the symposium is we need professional support. We need a group, a professional organization to kind of give us the infrastructure, tools and resources and education that we need to give the pharmacists all the info they need to build this into their own practices. If they want to break off and build their own practice, they need these tools and resources available to them. Support and enforce market value of a clinical pharmacist so that we don't show up to dispense a drug for 45 minutes and get paid 47 cents. So, and, historically, across the board, not just in long-term care, we have continuously sold ourselves short and gone the extra mile because we care. But it's not sustainable if we don't charge market value. And just as an example, let me just talk about, how a consultant pharmacist is paid, right? In a long-term care facility. Historically, it's been a side note. And so when you are offering a consultant pharmacist and you're the dispensing pharmacy, your objective is to get a dispensing contract. So you are willing to offer a consultant pharmacist below market value. And as long as we keep doing this, the longer it will take us to put in the effort into the consulting that will show that we deserve more. Mm-hmm. As long as we undercharge, we will put less effort into it, and we will never get the respect we need of our peers in healthcare. Just to make it relatable, if you're in long-term care pharmacy and you want to get that dispensing contract, you want to give them a good pharmacy rate. Now, there's two populations in healthcare: short-term rehab, long-term care. To get that contract, you have to price them how you're going to charge them for the drugs. The charges you're going to give them only apply to their short-term rehabs because the long-term cares are paid for by insurance, but not for the short-term care. So when you price it, Medicare will penalize you in the anti-kickback statute if you are offering drugs below market value because that is your goal to get the long-term care patients. You cannot shortchange the short-term side and undercharge there in efforts to get the big money grab on Medicaid on the other side. That's against the anti-kickback statute. The same thing applies to when we undercharge for consultant pharmacists. And think of it, when I've been talking to in these conferences across the country, it's come up on a number of occasions that, if we're going to start offering CCMs, annual wellness visits, incident to visits, yada, yada, well, then maybe we can start charging less for the consulting. But that's the same problem as charging less for your Medicare residents just so that you can get access to the Medicaid dollars. That's against the anti-kickback, and we can't keep undercharging for our services. We're never going to reach our potential if we don't get the reimbursement that we need and or deserve. All right, so I'm off my soapbox. Ensure the relevance and survival of clinical pharmacology services. So, and when talking about rebranding, is it time for us to start calling ourselves pharmacologists? Because we want to offer a specialty service. So if you refer it to an oncologist, that you would call them an oncologist, that's a specialty service, and that's what they're labeled. It's hard to label ourselves as a clinical pharmacist. In my opinion, maybe it's time we call ourselves a clinical pharmacologist when we're doing these collaborative services, because it's putting a specialty service in the front lines with that primary care and with that medical director. And you know, if anybody knows who Dan Buffington is, he has done this. He has opened his own clinic. He's a pharmacist that runs his own clinic in Tampa, Florida, and it's called Clinical Pharmacologists. And you should look him up. He's amazing. He has tons of billing codes that pharmacists can and should be using more often. And there's no legal problem with him calling himself a pharmacologist. So that is something for us to consider, just to show that we are a specialty service and specialty providers that are doing valuable things in healthcare.
Love it.
And then last of all, possibly redefine and create new terms that truly explain and emphasize our strengths. And so that kind of falls under, I already touched on that, the clinical pharmacologists. So the first one was ensure the relevance and the survival. So by utilizing these new terms and new services, we ensure our survival in the new healthcare as it changes and morphs into outcome-based reimbursement.
So folks, thank you guys so much for listening in, and Jaron for breaking down that list. So in the Pharmacy Rebrand Show, Jaron and I will be going through each one of those in detail, so you guys can learn more on what is value-based care and how is it different from fee-for-service, and why should that matter so much to pharmacists in the way that we're going to be treated in this new model in terms of payment systems. We'll be going over why a naming conventions can be so impactful to changing the way perceptions are from a one colleague to one patient looking at us as a different animal than the previous generations have looked at pharmacy, and everything kind of in between. So Jaron, I'm super excited for the journey together, buddy. I'm hoping that we get lots of participation. Thank you all for tuning in and listening. Any questions, shoot them Jaron and I's way. Any ideas, do the exact same thing. Because I think Jaron mentioned it earlier on. Really, it's about having the collaborative network, you know, of all of us pharmacists working collectively together to make sure that we're doing the right things for the next generation of our profession, because healthcare is changing extremely rapidly. And without us jumping on board at a very early juncture to see where is pharmacy going to be to position ourselves in the right spot, we're going to be in a really tough position, and the tea leaves are already turning when it comes to the major conglomerates that are employing pharmacists today. So once again, thank you guys. Jaron, always a pleasure, my friend, and we will see everybody next week.
You as well. Thank you.
All right. Have a good one, everybody. Good night.